Hey, ladies and gentlemen, that's in the room here. If you could take your seats, but also please make a point of signing in on the attendance sheet here, as we're getting into a new round now with the WebExing of these meetings and an automated notification system for the rounds. Which requires that we actually pay an annual fee for every person that we have on our distribution list. So we want to make sure that we have the updated list for people who are active locally. And if you're on the WebEx sign in, please make sure that we know about that. However we do that, and let us know. I guess there is a process for emailing in feedback about the quality of the WebEx connection and whether or not you can see slides and so on. And when Dr. Gianmarco's done her talk, we will pull through the WebEx manager here for questions from online. So thank you very much, everyone, for coming this evening for our the first of our 2018 pain rounds. We'd like to welcome Dr. Rosella Gianmarco, who is one of our neurologists in Hamilton, has been for a number of years with a particular interest in headache, and also the author of several books on headache, as well as a number of papers in the field, and has provided really remarkable service and support over the years in the field of pain management, in the neurological position on pain management, and particularly headache. So we're very pleased this afternoon that Dr. Gianmarco is here to update us on the business of recurrent daily headache and overuse headache and a couple of other summary topics here. But thanks, Dr. Gianmarco.
Thanks, Norm. I appreciate it. Boy, I can't wait to hear myself speak. Thanks for that introduction. I appreciate you inviting me, and I'm looking forward to speaking to you about medication overuse headache. I was asked to speak to you about headache and migraine in general, and to cover the topic of migraine acute prophylactic treatment, but I asked Dr. Park if I could speak to you about medication overuse headache simply because it's a topic that's near and dear to my heart, and it's something that I see probably more than anything else in the headache clinic, and it's the most challenging thing. And at the same time, the most rewarding thing that I see, because people get better, and they don't believe that they can actually get better. And it's a little bit challenging for them to get better, but once they do, it's very, very rewarding. But at the same time, the relapse rate is really quite high. They need close follow-up, but it can actually be a very simple thing to have them improve. And so what I'm going to do is, this is a clinical case that I'm going to walk you through to talk about the treatment of medication overuse headache. And you'll see that it's not evidence-based at all. It's purely anecdotal, and it's based from headache experts across the world. There are no clinical trials that talk about how you manage medication overuse headache. And so you're going to see that there's experience from across the waters. There's experience from the U.S. headache experts, and some experience from some of the Canadian experts, but largely based on what we do in clinical practice. And so that's what you're going to hear about tonight. You're not going to hear about clinical trials or a lot of epidemiological studies. You're really just going to hear about what we do in practice. So let's get started. This is about Sarah, and Sarah's a 45-year-old young woman referred for chronic daily headache to the clinic. This is a typical case that you see in the clinic, and she had headaches that started when she was 12 years old. They've gradually worsened in frequency and in severity over the last 5 years before she comes to clinic. And she describes 17 headache days a month where her headaches for 17 days are quite mild. She has mild nausea. But 11 days of the month, she has severe headaches that she describes as migraines. And with these headaches, she has photophobia. She's sensitive to light, sensitive to noise, and she has nausea. She's rarely free of headache in the course of a month. She has no autonomic features. She has no tearing. She has no rhinitis. She has no redness of the eye, no pupillary changes. And that's mainly her clinical presentation. So the challenge here is going to be to get to the next slide. Okay. There we go. She has, in addition to this, mild depression, but she claims she's been depressed because her headaches have actually been interfering with her life, and that's for about 3 years. Her sleep is disrupted. She has constant fatigue. She drinks about 3 Starbucks coffees a day with sugar, the equivalent of 960 milligrams of caffeine. So if you think about it, Starbucks has a huge amount of caffeine, and in terms of Red Bulls, 3 lattes, the grande lattes from Starbucks, are the equivalent of about 10 Red Bulls a day. She's had a weight gain of about 15 kilograms in 4 years. Her current headache treatments are OTCs. She takes NSAIDs 15 days out of the month. She'll take Tylenol number 3 9 days out of the month, and triptans of choice 11 days out of the month in total. So that's her current medication regimen when she comes into the clinic. Okay, so that's the story that we're going to base the whole discussion on. So a young woman who comes to clinic in her 40s, a long-standing history of headaches. Some of the headaches have migraine features half the time. The rest of the time she has this chronic daily background headache. She's been taking over-the-counter medication, prescribed triptan medication. She's probably taking medication at least 20 to 25 days a month. Nothing sinister about her presentation except for a slow escalation. So what we're going to talk about is the clinical presentation and the differential diagnosis of what she's presenting with today. So what's the differential diagnosis of chronic daily headache? I always tell my residents, when you get to the end of your history in the headache history, you should have some idea of what's going on with the patient, because most of the time, in 95% of the cases, your physical examination in a headache patient is normal. We always worry about those sinister headache cases where you're going to have a brain tumor. And you remember Arnold Schwarzenegger in that kindergarten movie where the student tells him, you must have a brain tumor. Well, that's very rare. And a mentor of mine, John Edmeeks, who some of you may have heard his name, always said, brain tumors and headaches rarely walk alone. So patients rarely present with headache when they have a brain tumor, particularly adult patients and elderly patients, because the brain atrophies. And when you have a brain tumor, it grows slowly, unless it's a metastatic tumor or a glioblastoma, because they have room to swell. As we get older, our brain atrophies, the brain shrinks, there's room for that tumor to grow. And it rarely presents with headache. It usually presents with confusion, personality changes, so it's not usually the presenting problem when a patient comes into the clinic. So when we see patients who present with chronic daily headache, the differential is very, very rarely a brain tumor. So how do we work it out when someone comes in with chronic daily headache? If it's chronic daily headache, you either have primary headache or you have secondary headache. And secondary headache is everything that includes your usual infectious, inflammatory, endocrinological, space-occupying lesion, neoplastic. So it's everything else but. You really only have 5 primary headache syndromes that can be chronic: migraine, tension-type headache, cluster headache, episodic or hemicrania continua, new daily persistent headache, and all the other TACs, so the trigeminal autonomic cephalalgias. Chronic migraine is typically, migraine, unilateral, pulsatile, associated nausea, sensitivity to light, noise, and smell. New daily persistent headache is very unique, and the one thing that makes it unique is these patients come into your clinic, they have a new headache that presents. It's chronic, it's daily, it's not debilitating, it's there every single day. It has features that are very similar to tension-type headache. It may escalate from time to time. It doesn't respond to any medication. But the one thing that makes it unique is patients will tell you, I remember this headache started on March 13th, 2015, and it never went away. And I'll tell you a little vignette about a patient I'm still following who I saw 20 years ago in the clinic, and she saw him, and I actually referred her to my mentor. He agreed with the diagnosis. She was 17 when I saw her, and she was the daughter of a veterinarian. Her father was a vet. He brought her to clinic. She was playing hockey. She went in to get changed, started with her headache, and it's been with her ever since. And I still see her 20, 25 years later. It's a chronic, daily, persistent headache that just starts for no reason. Very often it's preceded by a flu-like illness, a viral illness, sometimes a surgical procedure, and it's with them forever. It doesn't respond to anything that you do. But these patients function, and they're usually highly functioning, and they continue to function, and the headache does not interfere with their life. And that's what makes new daily persistent headache different from all the other chronic daily headaches. Chronic tension type headache, you see it every day. I see it much less because they don't come to headache clinics. Most of these are managed by the family doctors, and very often they have comorbidity with depression and anxiety. And then there's hemicrania continua. Sometimes missed, very often missed, because we don't think about it. Because it looks like migraine, patients come in, it's one-sided, it's side-locked all the time, and the thing that makes it unique, these people have autonomic features. And migraines can have autonomic features. You can get tearing with migraine, you can get red eye, you can get a runny nose, but these people have persistent autonomic features with their headache. They're holding their head, it's one-sided, but the thing that makes it unique is they respond beautifully to indomethacin. Indomethacin, 75 milligrams TID, the headache literally melts away. So those are the main chronic headache syndromes that are the primary chronic headaches that you would think about in your differential diagnosis. Okay, so once you've thought about those and you move on, you come to medication overuse. You have to ask about medication overuse in patients who have chronic daily headache, because if you don't ask, you won't get it. And many patients will not volunteer that they're taking medication as often as they're taking it, and you have to think about giving them a headache diary, questioning them on the frequency of their medication overuse. And if you just ask them about over-the-counter medication, they'll tell you, I'd only take it 3 or 4 days a week. If you don't ask them about triptans or you don't ask them about other medications, you won't get a full history. So by definition, according to the International Headache Criteria, medication overuse is greater than or equal to 15 headache days a month in a patient with a pre-existing headache disorder, migraine more commonly, and they have to have regular overuse for over 3 months of one or more medications that are used to treat acute headache, and not better accounted for by any other headache syndrome. So the interesting thing about this disorder is if you have a cluster headache patient who's taking 2 or 3 triptans a day to treat their cluster headache for 2 or 3 months, they don't develop medication overuse. If you have a patient who has arthritis and they're taking 12 aspirin a day, they don't develop medication overuse headache. They've actually looked at patients who are post-op patients who have severe pain and are taking analgesics every day. They don't develop medication overuse headache. So it's unique to migraine patients. There's something about the migraine brain that makes these patients susceptible to medication overuse headache. And if they're taking Tylenol for 2 days, aspirin for 2 days, triptans for 2 days, it's the accumulation of all of those that you have to consider. So it's not just one medication. It's all of them that you have to think about. And it's basically the circuit that develops. They start with headache, they start taking medication, they up the ante, they may up the Tylenol 1 to 2 to 3, their headache increases, they increase the number of pills that they're taking or the amount of codeine that they're taking, their headaches increase, their medication use increases, and so the circuit begins. And that's basically how it starts. These are the medications that are implicated in medication overuse according to the criteria. And with simple ones like acetaminophen, aspirin, and NSAIDs, it has to be greater to or equal to 15 days a month. However, if you look at the other, which is more migraine-specific meds, like the ergots, the triptans, or sometimes the combination, it's really only 10 days a month. So that's why when we give patients triptans like Imitrex or ergotamine or combination analgesics, we really put a maximum of no more than 2 days a month or 2 days a week, because you know they're going to take them 3 days, and that's why we say no more than 2 days a week for the triptans when we prescribe them. So patients will come in and say, oh, you know what, I'm taking them 3 days a week when I have my period or when I have my menstrual migraine. I take 4 triptans 4 days in a row, and they're getting all upset about medication overuse, but that's okay, because if they take 4 days in a row, but then for a week they don't take anything, they're all right. It's really the picture over a 3-month period of time that you have to look at. So who are the patients? What's the patient demographic that's more likely to get this? It affects about 1 to 4% of the general population, and these patients are typically female that get medication overuse headache. So for every 1 male, 3 to 4 females are going to get it. And in the Canadian Headache Clinic, when we've looked at it, about 20% of the patients referred have medication overuse headache. And most of these people have chronic migraine as well as medication overuse headache. Usually starts earlier in life than patients who have chronic migraine. And there are other risk factors for medication overuse headache, which I will tell you about. So what does this patient look like when they come to your clinic? What are the kind of features that they're describing? Usually the headache that they talk about, we talk about it as being a fluid headache. So it's not a typical headache of any kind. By fluid, I mean it moves around. It could be frontal, it could be temporal, it could be occipital, it could be throbbing, it could be pressure, it could be stabbing. Every day it's different. And they'll typically tell you that when they come into the office and you ask them, how many days do you have a headache a month? Well, I have a headache every day. And then you try and break it down. Well, tell me about, is your headache the same every day? No. I have a headache every day. Are there some headaches that are worse? Yes. I have a more severe headache maybe 2 times a week. And then you find out what that severe headache is like. And typically that one's more like a migraine. But the background headache is diffuse. It's pressure, sometimes aching, sometimes throbbing, but not disabling. So if you grade it, it's often a 2 or 3 out of 10. And that's their medication overuse headache. That's their usually first thing in the morning when they wake up, and the first thing they do is reach for their medication. They take their medication, the headache gets better for a couple of hours, and then it tends to come back in the afternoon. They'll describe feeling foggy. They're not mentally clear. They can't concentrate. They can't focus. Very often they have difficulty with concentration and memory, and there's usually some comorbidity with depression associated with these people. They may have vasomotor features, they may have rhinitis, they may have a runny nose, they may have some tearing of the eyes. It's not really autonomic. They don't have sort of a tearing like they do when they get cluster headache, but they may just find their eyes water, they're irritated, they may have a runny nose, they may feel like they have cold symptoms very often. And very, very often they have a sleep disturbance, they have depression, they may have some underlying irritability or mood-related changes. That's what these patients typically will look like. The costs for medication overuse headache are actually higher than migraine. These patients repeatedly go to their doctors, but more importantly, they go to their pharmacy and they're buying over-the-counter medication over and over and over again. The annual costs are over $5,000 per person in terms of what's costing the system, and 92% of those costs are indirect. So in other words, failed prescriptions. They'll go to their doctor and get prescriptions for triptans or prophylactic medications, and they don't work for them. They'll go to Emerge and get treatment for their migraines, and it doesn't work for them. They'll have absenteeism from work. So that's what I mean by indirect costs. Compared to patients with episodic migraine, with chronic migraine, they miss more days at work and school. And when they do go, they have presenteeism, meaning they're there, but they're not functioning very well. They're not very productive. They have poor quality of life, and they use a lot of healthcare resources. Typically, they're in their middle age, 40s, more commonly women, low socioeconomic status, low educational level. So what are the comorbidities associated with medication overuse headache? And this is based on Richard Lipton, who's one of the epidemiologists, neurologists in the States that's done a lot of work in the area of migraine medication overuse study. He's actually surveyed thousands of patients who have migraine and medication overuse headache. The patients I've already mentioned have depression, they have anxiety. A lot of them have sleep apnea and not diagnosed properly. Obesity, diabetes, arthritis, chronic pain syndromes, chronic back pain, and facial pain. And when you look at these patients, they have certain risk factors for developing medication overuse headache. Obviously, they have a background history of migraine, but a lot of these patients aren't physically active. They don't exercise. They don't look after they don't look after themselves in terms of exercise, dieting, in terms of what they're eating. They use caffeine in excess or alcohol. They have other dependencies in terms of drugs, alcohol, and caffeine. There are usually some stressful life events in the last year or two before they started overusing. Some of them have a history of head injury or concussion in the past at some time. Many of them smoke. And if they look at their headache history, a lot of them have a high baseline frequency, so they have headaches that are more frequent before their medication overuse started, and inadequate or incomplete treatment. So these are the patients who have gone to their family doctors and have had 4, 5, 6, 7 headaches a month and have never been put on a triptan when they should have been given prescriptions for codeine or Tylenol with codeine or Furanol, and where they should have been treated with migraine-specific treatment, or should have been put on a prophylactic medication many years ago and were never treated prophylactically with migraine medication. So when they looked at these risk factors, they tried to break them up into things that we can do. We've recognized the risk factors. What are the things that we can change? What are the things that are modifiable? And what are the things that are presently being investigated? The things that are not modifiable, we can't do anything about their age. We can't do anything about their gender. Females are more susceptible to developing this. We can't really change their socioeconomic status or their educational level. And we can't change the past history of a head injury. What we can modify is the attack frequency. So in other words, we can get the message out there that if you see patients when they have migraine and they're young, you can deal with their migraines more effectively. You can treat them effectively, you can put them on prophylaxis if you recognize they're having them more frequently, and hopefully prevent medication overuse from occurring. You can deal with issues of obesity if you recognize that at a young age. You can prevent medication overuse by seeing patients in follow-up and not just giving repeat prescriptions with narcotics and opioids. Stressful life events can hopefully be dealt with through the family physician. Caffeine overuse can be dealt with, snoring by doing sleep studies and dealing with it appropriately if it is an issue, and then managing other pain syndromes. The things that are being investigated, allodynia, central sensitization, seems to be an issue in patients who develop medication overuse headache and with their migraines. We all know that the longer you have migraines, the longer they go untreated, the more likely you are to develop central sensitization and allodynia. Pro-inflammatory states, pro-thrombotic states, and specific migraine genetic states may predispose you, although we don't know. Right now, that's just being looked at. Migraines can go from being low-frequency episodic 2 or 3 times a month to high-frequency episodic to developing chronic migraine. And we know that if you have chronic migraine and we leave these people alone, we don't do anything to them, they can go right back into becoming episodic migraine, probably at a rate of about 45 to 55% by not even touching them, by not even treating them. So what you can tell your patients is, you know, it's hopeful. Without even doing anything, you can go right back to becoming episodic, so it doesn't mean that it's a curse of life and death. You can go back to becoming episodic even without treatment, but certainly treatment is available, and it can be much, much easier if we treat you. So why do people overuse medication? Usually there's underlying personality disorders, there's underlying behavioral disorders, patients have drug-seeking behavior, poor coping strategies, dependent personalities. And with migraine, there's very, very much a type of personality where they anticipate their migraines occurring. If you talk to migraine patients, many migraine patients who've had chronic migraine anticipate the next attack coming on. So they won't make plans. They anticipate a migraine coming. They're afraid of making plans to go for dinner, to go for an event, because they're so afraid of a migraine occurring that they take their medication in anticipation of a headache occurring. And very often that's what drives them taking their medication in anticipation of a headache occurring. And so that's what starts the behavior of medication overuse happening. When they look at what medications are the most likely, the risk is highest with barbiturates and with opioids. Barbiturate use 5 days a month seems to be one of the things that occurs more commonly and starts the whole trend. And with opioids, when they start using in the order of about 8 days per month, it seems to start the trend with medication overuse. Years ago, I was involved in the Canadian Headache Outpatient Registry database. It was called CORD. And basically, it was across Canada, everybody who had a headache clinic participated in this, and we just looked at patients coming into the clinic randomly, and the ones who were diagnosed with medication overuse, we looked at what medications they were using and the prevalence of overuse. And NSAIDs were at the top of the list. In Canada, opioids were the second, triptans the third, barbiturates and ergotamines were at the bottom. I think that would probably change a little bit today. Perhaps I don't see a lot of opioids being prescribed as much in my clinic, and so they're still very common. But it'll be interesting to see what that trend looks like now. That was back in 2008 when that was published, so I'm not sure how that will change today and over time. It's different in the States. Opioids were at the top of the list in the U.S. I'm going to skip over this one because it's not terribly relevant here. So the important thing with medication overuse headache is not the number of doses that they're taking, but the number of days that they're actually taking it. So even if they're taking 30 Tylenol, that's not as relevant as the number of days that they're taking it. So the number is 2 days per week to make a diagnosis of medication overuse headache. 2 days per week, consistently every week for 3 months. My record in patients was 100 Tylenol a day in the last 25 years. Yeah. And I think 4 triptans a day. So how do we manage these patients? And remember I told you that there is no one single way of managing them. Boy, this thing is really tricky. Okay, let's try again. Hang on. Yeah. Okay. There's no way to manage these. There's no one single way to manage them. Most of the patients who have medication overuse headache, it's like a light goes on when you tell them that that's a possible diagnosis for their chronic daily headache. And a lot of patients, when you tell them that that's what one of the possibilities is for their chronic daily headache, some of them will say, okay, I'm just going to stop and let's see what happens. They don't want any preventative medication. They simply want to stop their medication. And oddly enough, when they come back after 2 months, they're better. Their chronic daily headache is better. They still have their migraines, but they're better. And these are typically patients who are overusing triptans. They do the best. They stop them. Or patients who are taking NSAIDs or Advil, ibuprofen, or plain Tylenol. And they seem to do the best. Patients who are a little more challenging are the ones who are on opioids or caffeine and who have been doing it for a much longer time. So there are different approaches for those patients, and I'll go over those with you now. Okay. So the main objectives are to reduce headache frequency, and you can do it with or without pharmacological intervention. You want to monitor BMI, and if it's an issue, address it and see if that's something that can be changed. You want to restrict the use of acute medication to no more than 10 days per month, and one of the principles is change their rescue medication. So if they are overusing NSAIDs, you want to take the NSAIDs away, whether you taper or stop abruptly, and you want to give them a rescue medication that is something other than what they're overusing. So you'll replace it with a triptan with restrictions of no more than 2 days a week, or if they're overusing triptans, you'll take the triptan away and replace it with a rescue medication, possibly an NSAID, possibly Tylenol, something of your choice. You want to restrict their amount of caffeine if they're overusing. If they have a sleep disorder, you'll investigate it, send them for a sleep study and address that, and screen them for any other psychiatric condition if they have it. If there's depression, if there's anxiety, deal with that, send them to the appropriate places if you have that available to you. The biggest problem that we have in Ontario is lack of resources. There's a program in Calgary called the CHAMP program, and they have resources, they have multidisciplinary clinics, and so it's a dream. You can send them down the hall to the psychologist, down the other hall to the social worker, and down the other hall to the massage therapist. We don't have that here, and so it's a little bit more challenging. But the basic goals of management is to reduce the headache frequency, the headache intensity. You want to reduce their disability. You want to really get them away from these potentially life-threatening drugs. And by doing that, when you reduce their drugs and their medication overuse, you can re-challenge them with some of the acute medications because they will work better. These are typically patients who come in and say, I've tried all the triptans, they never work. I've tried the anti-inflammatories, I've tried all the preventatives, they don't work. You'll find that when you reduce their medication overuse headache, you can re-challenge them, and they may work better for them. So I encourage you to try that. And their quality of life absolutely increases. So there's a lot of controversies in medication overuse, as you can imagine. Do we withdraw medications and initiate preventative medications? Do we abruptly withdraw medications, or do we taper them? Do we bridge, or do we not bridge? And I'll go over that in a minute. And which which prophylactic medication do we choose? And I'll start off by saying that this is always a debate at the headache meetings. There's always the right side and the wrong side. There's always the Americans and the Europeans, and everybody has a different approach. And nobody comes away with the right answer. And a lot of times it's very dependent on the patient that you're treating. And basically the approach that I take is I look at what medication is being overused to make a decision, and I talk to the patient and I present them with a couple of scenarios, and they take part in the decision as well in terms of how they want to approach it. The most important thing is education of the patient, and if there's a family member that you can get involved, so much better. I tell them that things are going to get worse before they get better because their headaches will escalate as you're taking them off their overused medication. I always start with natural things like lifestyle management. We talk about sleep hygiene. We talk about caffeine reduction, exercise program, good nutrition. There are certain things that we go through just talking about lifestyle, and that's 3/4 of my discussion with all of them. We initiate a diary, and the diary is critical. It's important for them and for me, but more importantly for them because it tracks their headache frequency, it tracks their medication use, it tracks any potential triggers, and they can actually see progress in their diary by doing it the whole time that we're reducing their medications. You give them a realistic schedule for titration. So I write down every single week how much they're cutting back on their medication so that they have a diary and they have it in front of them that they can see. And then I give them the acute rescue medication. I never take something away without giving something back to replace it. I talk about medication overuse headache and make sure that they understand it. I have a brochure and a pamphlet that was written way back in 1990. There's been another one rewritten this year, but it's not as good. So I've just given the old one because it's as complete as anything, and it has diaries at the back of it. And then with their new medication that I give them, very clear instructions not to overuse more than 2 days a week when they're taking their rescue medication. So these are basically the principles of migraine management, and it applies to medication overuse as well. These patients are seen probably every 2 weeks as they're coming off their medication. So it's demanding from a follow-up perspective. Once they're off their overused medication, then they go to regular follow-up every 2 or 3 months. So there's a lot of hand-holding involved, even though the visits may be very short. We go over their diary. I change the medications or alter them if I have to, and they're on their way. But just knowing that they have an appointment in 2 weeks is good for them to know that they're coming back that frequently. I never prescribe narcotics or barbiturates for their headaches in my practice, and I never give them follow-up prescriptions in this situation without at least seeing or speaking to them. Not that there isn't a role for it, I'm just saying that that's my practice. So non-pharmacological approaches I've already talked about. The obesity is an issue, and actually there's a couple of small studies that have looked at reducing BMI and demonstrating an improvement in migraine, as there is in things like idiopathic intracranial hypertension as well. So it's not something that we just talk about. There's actually some evidence for it, so it's worth definitely looking at. These are definitely things that should be looked at, difficult unless they have coverage for it, or unless you have someone that can help you with this and the support for it. But cognitive behavioral therapy, biofeedback, relaxation, there's lots of apps, there's lots of things on the internet. So if you can refer them to some of these sites, there's lots of wellness apps now that they can look to, so they can implement some of these things in their therapy. If they have coverage for massage therapy, I send them for massage therapy during the time that they're weaning off their meds, because I think that that also is very helpful for them. So, I mean, there's controversy. Does the offending medication need to be stopped abruptly? And does it need to be weaned? And what prophylactic medication do you use? So do you wean it abruptly? Do you stop it gradually? I ask my patients. First of all, it depends on what they're taking as well. If they're taking barbiturates, if they're taking opioids, if they're taking a lot of codeine, I tend to gradually wean them off. Obviously, I'm not going to stop barbiturates. I don't see a lot of patients who are taking a lot of barbiturates, oddly enough. If the patient is really dependent on their medication, has a dependent personality, they may prefer to wean off their medication, and that's fine. If that's what they want, then I'm happy to do so, and I give them a titration schedule to wean them. Botox is actually very good for medication overuse headache in the studies that were done for chronic migraine. Many of the patients that were entered into the study also had medication overuse headache, and they were told nothing about weaning their meds. They were left alone, they continued on their medication, and they found in a preempt study that as their headaches went down, the patient's overuse of medication also went down without ever being told to come off their meds. So it's actually something that's very, very good for patients with chronic migraine and medication overuse headache. It's one of the tools that I use to get them down on their medication if it's difficult for them to do it on their own. Definitely something to think about. It's associated with other problems, as you know. If they're overusing NSAIDs, if they're using Tylenol, you run into problems with GI issues, dependence, depression, and so on. So it's not just the migraine and the medication overuse, it's other medical issues that are a problem when they're using these medications. Analgesic nephropathy, GI issues, and so on. So what do we do about tapering? How do we taper? What can we do with their other medications? What do we mean by bridging? So if they're overusing butalbital or combination medications, we recommend tapering gradually. What do we give them as an acute treatment or a rescue medication? You can use either a triptan or an NSAID. And consider bridging. So by bridging, I mean as you're tapering, we give them something for a 2 to 3 week period of time, so a short duration while they're getting off their butalbital. So we can give them a long-acting triptan, something called naratriptan or frovatriptan, 12 to 24-hour half-life, and you can use it BID for 2 weeks. Nothing wrong with that, and they're not going to have a problem with that. Or you can give them a long-acting NSAID, BID, again, for 10 days. They shouldn't have too many problems with that. The other alternative, and this is one of the ones that I tend to do more commonly, is I'll give them prednisone 50 milligrams for 5 days, taper 10 milligrams a day until they're off it. So 10 days of steroids. And that helps them get through that first 10 days where their headache is going to get much worse as they're tapering off their meds. So that's one approach. If you're going to come off butalbital abruptly, which is much less common, you can substitute phenobarb and taper. You can add a triptan or an NSAID, and you can again go with the same bridging. If they're taking an opioid, you can do a similar approach. What if they're taking a triptan or an ergotamine, a migraine-specific medication? You can stop those abruptly, and there's not a problem. They won't get into withdrawal, except for the ergots. They might get a little bit shaky. They might have a seizure. The ergots aren't around really that much, so you don't really see it that much anymore. So you might taper the ergots a little more gradually. The triptans, you can stop them cold. Their rescue medication would be an NSAID in that situation. And as a bridging, I would tend to use either a steroid or a long-acting NSAID for 5 to 10 days in that situation. And if they're overusing NSAIDs, many people are taking Advil every day, naproxen or Aleve. You can stop that abruptly or gradually. You can give them a triptan as an acute rescue. and you can use a long-acting triptan as a bridging. The other thing that I will do in these situations is for that 2 or 3 week period that they're having a bit of a hard time, I'll put them on amitriptyline 10 milligrams at bedtime, or I'll give them gabapentin 300 milligrams at bedtime. And then when they come back in 2 or 3 weeks, if they're still having issues with sleep, I may leave them on it, or if they're doing all right, I may take them off it. In addition to this, if they have a background history of migraine, and their migraines are still percolating in the background, I might start them on a migraine prophylactic medication, maybe topiramate, maybe propranolol, maybe candesartan. So it really depends on what the clinical picture looks like. Any questions about that? Okay, I think we've talked about that. And I think we've talked about Botox as well a little bit. That's really the only clinical trial, and that was actually for chronic migraine more than medication overuse headache. This was just a systematic review that was done, published in Cephalalgia. It was not a clinical trial. He looked at a series of articles, and they talked about treatment, prognosis of medication overuse headache. He reviewed a whole series of articles that were published between 2004 and 2014, looked at the level of evidence to determine practice guidelines, and he reviewed 68 articles. This was Chang and all, just to look at the approaches to medication overuse headache, and found that the evidence supported early discontinuation of the overused medication, and found that it was, he found that there really wasn't a lot of evidence. There were no real good control trials, but he did find that in the studies that he, in the articles that he looked at, that adding prophylactic medication to early discontinuation seemed to lead to a better outcome rather than just stopping the medication on its own. Chronic migraine and medication overuse headache, Botox and topiramate, talked about 2 of the trials. The evidence was limited because the analysis was post-hoc. But those were the 2 best agents that you could consider for prophylaxis, and basically suggested discontinuation of overuse medication with the addition of a preventative medication. Those groups of patients who were given prophylaxis seemed to do better in the papers that he reviewed. So if you're going to discontinue meds with MOH, add a prophylactic medication, and the outcome looks like it's probably better. But again, that's just based on reviewing papers. I don't know what happened to that, sorry. So what are we looking at in the future, and future approaches to management? Weight loss, are we looking at things like reducing BMI, lap bands, gastric bypass? Is that a realistic thing to consider for the future? Occipital nerve blocks, there is some evidence to suggest repeated occipital nerve blocks in chronic migraine may show some benefit. There was some work with occipital nerve stimulators for chronic migraine. Showed some promise, but they ran into problems with things like lead migration, and so it's kind of fallen off a little bit. I have several patients that have had occipital nerve implants done for chronic migraine. 2 of them did well, 3 of them didn't, so that's my small trial. Non-invasive vagal nerve stimulator, I don't know if you've heard of GammaCore. It's a stimulator that patients are basically just applying externally. It's about this big. It's about $400, and they just stimulate the vagus nerve. There's about 4 clinical trials using it in chronic migraine, cluster, and episodic migraine. It's very well tolerated. There's nothing in medication overuse headache, but it's non-invasive, and it's about $400. So it's something that might be looked at in medication overuse headache. Single pulse TMS, transmagnetic stimulator, not available in Canada, available in the US. A little cumbersome, it's a big machine. This was the home of it after all. But you know what? We laughed in the beginning, but not laughing now, because it's definitely the way things are heading with migraine treatment. And stay tuned for the monoclonal antibodies, because they will probably become a reality. They're in Health Canada now, waiting for approval, and it's looking very promising. They will likely be approved and ready to go probably in the last quarter of this year. For migraine management for prophylaxis, and these will be a once-a-month injection indicated for episodic and chronic migraine. So very, very promising. And there will probably be some work looking at their use in medication overuse headache. No studies in it so far. So overall, up to 3/4 of patients improve with withdrawal of overused medication. Central sensitization and allodynia may be normalized when you get them off their meds. The relapse rate, however, is high, about 40% in the first year when you get them off their meds, so they need follow-up. If you stop their meds without doing anything, 2/3 of these patients improve. But the risk factors for relapse include patients who have long-duration headaches. So if they have headaches that last 2 or 3 days at a time before they got into medication overuse headache, patients whose headaches occurred frequently, so if they had 2 or 3 headaches a week before they got into trouble, and patients who've had multiple drug failures. So if they got into medication overuse headache and they had 2 or 3 or 4 prophylactic drug failures before they got into this, they're likely the ones that are going to relapse. If you add behavioral therapy with medication treatments, patients seem to do a little bit better. So if you have that available to you, I'd encourage you to use it. Okay, we're almost there. So in summary, great. Medication overuse is common. You can diagnose it using the ICHD criteria. The best thing is prevention. It can potentially be caused by any of the medications we use to treat migraine. It's associated with comorbidities, and it's important to treat the comorbidities if you recognize them. It's usually reversible, and it has a good prognosis, but it also has a high relapse rate. The best treatment for it is the prevention of it, and patient education is the key. And future devices are around the corner, so there's other things that we can offer these patients. And patients do well, so something to consider. But it has to be recognized. Okay, questions? There's a question? Can someone without migraine have MOH? So someone who's had a motor vehicle accident taking Tylenol?
Yeah, so the question is to do with whiplash. Whiplash associated.
No, I mentioned before, patients who develop MOH have a history of migraine. And patients who are taking analgesics for other reasons tend not to develop medication overuse headache. So it's unique to migraine patients. Yes?
What about the situation where you have someone who has, let's say, fibromyalgia, they have chronic migraine, or let's say some other pain condition, they're on chronic opioids. So then, essentially, you're stuck in the situation where the chronic opioids are treating one pain, and then if you were to withdraw it, so you're kind of stuck, right? So what would you do then?
Can you repeat
Yeah.
the question?
The question is, if you have someone who has another chronic pain condition, such as fibromyalgia, and they're taking analgesics for this other chronic pain condition, but they develop medication overuse headache, and they have migraines, then what do you do to treat it? And the answer is, good luck. You know, because, and it happens all the time, because very often patients who have migraine have comorbidity with fibromyalgia and other chronic pain conditions, and it's true, chronic pain, and it's impossible. You cannot take them off their pain medication. You know, it's different if they're overusing triptans, and you can try and take them off their triptans, but if they need their other chronic pain medication, it's very, very difficult to tell them to stop everything because they simply can't. You can maximize their other chronic pain condition, but it's hard to tell what they're taking for what condition. If you can try and sort it out, but it's really very difficult.
Would you just place an emphasis on prophylactic and attempt to perhaps withdraw some of the offending agents?
Absolutely. If you can sort out what they're taking for what condition and try and minimize what they're taking for their migraine and focus on prophylaxis, that's exactly what you do. Yep.
One of the other questions online had to do with using Suboxone as a means to support withdrawing them from short-acting opioids.
You can do that. Yep, absolutely. Or clonidine was the other one that we can use for barbiturates. Yep. Yep. Do you see medication overuse headache in your pain clinics? You must,
Never,
right?
never.
All the time. Do you treat it? Do you withdraw them, or do you try? What do you do with them? Do you try and manage them by withdrawing them, or?
So this past week I saw one, and I'm a pharmacist, so I can't do it independently, but I informed the family doctor it was a drug withdrawal, so the patient agreed with drug withdrawal. So saying like obviously it's really the balance, but I mean you just want to go.
Yeah, and if patients want to do that, I support it 100% because, you know, if you just withdraw, 2/3 of them get better with just withdrawing what they're taking, and they're so satisfied when they come back. They're so proud of themselves, and they should be, right, because they see the results. Yes?
Do you see it as well with patients that are on long-acting opioids, or is it strictly the immediate release?
Do you see it, the question was, do you see it with patients on long-acting opioids or just the short-acting? No, you would see it on long-acting as well. Yeah, but I think the ones that are on long-acting opioids, they're not on long-acting opioids for their migraines as much. I think they're on for other conditions. That's what I see, right? Yeah.
Any other questions? Yeah.
Sure, this is all drug-related, but so with triptan, it's like, is there, I don't know if there's any evidence, but is there more of a likelihood with a shorter-acting triptan because you're essentially would be taking theoretically more doses in order to treat and rebound migraine? Would there be more of an incidence versus a longer acting, or is there?
I don't think, the question is there more of a chance of developing it with the shorter acting triptans because we're taking them more frequently? And no, I don't think so. I don't think anyone's really broken it down that way, to be honest. And in my practice, I haven't noticed any difference.
Okay, any other questions? Dr. Gianmarco, thanks very much. Thanks.
Pleasure. Thanks.
Good. So just a reminder, if you have not signed in and you wish to be on the mailing list for rounds, please do so. Make sure we've got your email address so we can keep you on the list. Please do submit, what are those things called, evaluations. We actually read them. Also, any suggestions about other topics you'd like to see, and we'll feed back to Dr. Gianmarco your comments from the evaluations. If you need an attendance certificate for your continuing education records, there's one, they're here. Okay? Thanks very much, everybody. Where are we going?